Hemorrhagic disorders. So the hemorrhagic disorders usually constitutes amongst the cells which are present in the hemorrhage. They could be they constitute the platelets or other clotting factors which are usually present, helping in clotting during bleeding when the patient is exposed to bleeding on injuries. So these all constitute the hemorrhagic disorders. They could be platelet disorders, vascular disorders, coagulation disorders, or fibrinolytic defects, or disseminated intravascular coagulation. Coming to platelets, it is important to know what a platelet is before knowing how a platelet disorder approaches. Platelets, they are usually small. They are they are cells which are present within the blood, and they morphologically are small, discoid, and do not have any presence of nucleus within them. So they are known as non-nucleated structures, and they usually, on staining, they appear red purple because of the presence of the granules which are present in them. And they measure 1 to 4 micrometers in diameter, and in the blood usually they are present in up to a range of 1,50,000 to 4 lakhs per microliter, and they are synthesized, they are distributed in circulation as well as in the spleen. And spleen, they are present up to 30% of platelets, whereas in the circulation they constitute 70% of the total platelet count. And the lifespan of the platelets, it's usually 7 to 10 days. Usually it takes about 1 to 10 days for a platelet to be created. And coming how the platelets form. So usually the platelets, they are derived from the bone marrow. Among the bone marrow, it is from the myeloid series of the cell. And these platelets, they are formed from the thrombopoietin, which is a protein which is present from the which is synthesized in the kidney and the liver. This thrombopoietin, it starts showing its function on the by initiating the myeloid stem cell differentiation. Once the thrombopoietin starts being activated, it differentiates the myeloid stem cell into a megakaryoblast. This megakaryoblast is a cell which appears oval in shape and has a larger nucleus which is present, centrically placed nucleus, and this megakaryocyte further is being converted into a promegakaryocyte. This promegakaryocyte is produced because of the division of the nuclear material in the megakaryoblast. The nuclear content in the megakaryoblast, it divides and results in the formation of a promegakaryocyte. This promegakaryocyte, it contains more than 32 times the diploid nuclear material of that in the megakaryoblast. That is, it contains 32 times more the nuclear material than that in the megakaryoblast. So this promegakaryoblast further differentiates and results in the formation of a megakaryocyte. This megakaryocyte, it appears usually with the presence of many extensions from the cytoplasm. They are known as pseudopores. These pseudopods give rise to individual platelet cell. So usually it is about 1,000 platelets which are formed from each megakaryocyte. So this explains the formation of platelet. Coming to the functions of platelet, usually the major function of platelet is to form a clot, that is a fibrin clot. This is also known as a platelet plug. So primary hemostasis, it is divided into primary hemostasis and secondary hemostasis. Primary hemostasis is further divided into 3 stages. In this stage, we see that the platelets which are being formed, which are being derived from the myeloid stem cell, they usually aggregate together with the help of certain receptors which are present on the platelets. The platelet or surface of the platelet, it consists of a receptor which is a glycoprotein, and this glycoprotein helps in binding of the platelets with the adjacent platelets. Once these platelets have been being binded to that of the adjacent platelets, that is platelet adhesion occurs. These platelets are usually inactive when they are separate, but once they start binding or others, this causes the activation of the platelets, and these platelets contain certain granules within them, and these granules, they cause they consist of ADP, ATP, and certain platelet factors such as platelet factor 4, also constitutors of clotting factors. They are the clotting factor 5 and clotting factor 8. Other than that, it also constitutes of von Willebrand's factor, and these all factors are usually present in the granules of the platelets. Once these platelets get activated by the platelet adhesion, they release these factors, factors which are present within the granule, and they cause And these factors together they cause the aggregation of the platelets. That is, the platelets, in between the platelets, there are certain fibrin which is formed, which forms as a plug, and it interconnects the adjacent platelets. And this stage comprises the platelet aggregation. So this is being shown in the picture. That is, initially platelet occurs in a non-activated form, and this non-activated platelet, once there is addition of this platelets with the others adjacent present platelets, then this results in formation of platelet adhesion. And this platelet adhesion, that is the activated platelets, they release certain granules as shown in the second picture, and then there is activation of these granules and their associated function, and then followed by that is the last picture showing platelet aggregation. Then followed by primary hemostasis constituting of platelet adhesion, release and aggregation. It is followed by secondary hemostasis. This secondary hemostasis is being comprising of the complement cascade reactions. These complement cascade reactions, they are intrinsic, they constitute the intrinsic pathway, extrinsic pathway, as well as a common pathway, which is being explained in the further session. Coming to the disorders of platelet functions, it is also important to know how the platelet functions have disorders, and they are hereditary disorders. These hereditary disorders, it could be because of the defect in the platelet adhesion. This platelet adhesion adhesion in the platelets is being seen in certain syndromes such as Burnett-Solier syndrome, where there is defect in the deficiency of the glycoprotein or the surface receptor which is present on the platelet, results in deficiency in the adhesion of the platelets because of the damage to this glycoprotein, and results in Burnett-Solier syndrome. The other condition where we see there is defect in platelet adhesion is von Willebrand's disease. This similarly has the glycoprotein similar to that, but whereas the other adhesing factors which are required, that is the integrin glycoprotein, they are defective. Because of that, the platelet adhesion is also defective. Next, coming as defective in the platelet aggregation. This seen as a condition known as thrombocythemia. The platelet, they aggregate, but there is lack in the formation of fibrin plug, which results in degradation of this platelet aggregate which have already fused to each other. So this is a defective platelet aggregation, usually seen in condition known as thrombocythemia. Next, coming as the disorders of the platelet release reaction. That is, the entire other systems such as platelet adhesion and platelet aggregation are normal, but whereas the platelet release from the activated platelets, it is being compromised in this hereditary disorder with platelet release reaction. The next coming factors or disorders in the platelet function, they are the acquired disorders. Usually it is seen in aspirin. This aspirin, it usually hampers the binding of the platelet adhesion when these patients are taking aspirin, when the patients are on aspirin, and this results in a defect either in the platelet aggregation, that is in any stage of the primary hemostasis. So patient is usually advised to withdraw the aspirin therapy. And other conditions such as in megaloblastic anemia, as well as certain hemolytic anemia and certain cancers, we see that they are disorder platelet function. Coming to the disorders of platelets, when there is any disorders in the platelets, as a platelet forms a platelet plug, that is, or also known as, it helps in controlling the hemostasis. They produce any disorders in the platelet that result in bleeding condition. And these bleeding disorders, they are explained by three mechanisms. The first mechanism being, it is either because of reduction in the number of the platelets, and this reduction in the number of the platelets is known as thrombocytopenia. And then it could also be because of the rise in the platelet count. That is, when there is any rise in the platelet count, it is known as thrombocytosis. Or otherwise it could also be because of a defect in the platelet function. This platelet function, it could be either in the primary hemostasis or secondary hemostasis. In the primary hemostasis, it could either be in the aggregation stage, adhesion stage, or release reaction stage. So any hampering functions or altering impairments in these all these stages can result in bleeding. Next, coming to the common causes where we observe this disordered platelet function is drug-induced thrombocytopenia and idiopathic thrombocytopenic purpura and thrombotic thrombocytopenic purpura. So these are the conditions where we see that there is any impaired platelet function. Next coming is starting with thrombocytopenia. What exactly thrombocytopenia is? Thrombocytopenia is reduction in the number of the platelets, and it is defined as reduction in the peripheral blood platelet count below the lower limit of normal, and it is usually the platelet count ranges from 1,50,000 per microliter to 4 lakhs. But we see that it is below that of the lower limit, that is, it is below 1,50,000 per microliter. And the major etiological factors for this thrombocytopenia to occur is either because of an impaired platelet production, which we can see in generalized bone marrow failure, such as in aplastic anemia, we see such bone marrow failures, or otherwise even in selective suppression of the platelet production on any drug intake, such as alkylating drugs which are being taken, or any aspirin kind of drugs or antibiotics. They also have a role in suppressing this platelet production, which in turn impair the platelet production and result in thrombocytopenia. The next etiological factor is accelerated platelet destruction, where we see that it is because of immunological thrombocytopenia, where it is because of immunological complexes which are formed against the functions of the platelets by forming immune complexes against the receptors which are present on the platelet, and thereby altering the platelet aggregation or adhesion and resulting in thrombocytopenia. So this is one of the immunological thrombocytopenic condition seen in accelerated platelet destruction. Next coming is increased consumption is also one of the reason why the platelets get destructed accelerated. The other condition is splenic sequestration, usually seen in conditions such as splenectomy. Since spleen is one of the area where the platelets are present, 30% of the total platelet count, amongst the total platelet count present in the body, 30% is stored in spleen. So any splenectomy conditions can also result in thrombocytopenia, that is decrease in the number of total platelet count. It is dilutional loss can also be one of the reason, such as in severe burns or conditions like overhydration or underhydration can also result in dilutional loss, which in turn causes decrease in the total platelet count. There is a picture showing a thrombocytopenia, that is decrease in the total number of the platelets, which shows almost it is devoid of the platelets. That is, there's completely absence of the platelets in this picture, peripheral blood smear. Next coming is drug-induced thrombocytopenia. Usually it is a thrombocytopenic condition, that is decrease in the platelet count because of the intake of the drugs, and this most commonly is seen in conditions such as when the patient is on corticosteroid therapy or taking alkylating drugs, or it could be also because of antibiotics or any diuretic intake can also result in drug-induced thrombocytopenia. In these drug-induced thrombocytopenic conditions, we see that there is depressing megakaryocyte production. This depressing megakaryocyte production is in turn because of the formation of drug antibody complex. This drug antibody complex, it is usually formed when the drugs they form antibodies against the platelets in turn. So this results in drug antibody complex. These damage the platelet, and they usually said to be innocent bystanders. That is, it is so called innocent bystanders because these drugs do not have any direct effect on the platelets, rather they form the antibodies against these platelets and result in drug-induced thrombocytopenia. And other conditions, clinical features where we see is formation of acute purpura. That is, they are the purple or red color pinpoint hemorrhagic areas which are seen in the skin because of the drainage of the blood into the skin. And the other condition is lowered platelet count, that is decrease in the total number of platelets. And the bone marrow picture here on laboratory investigations, it shows that they are normal megakaryocytes or otherwise they are increased in the number of megakaryocytes. Since they are damaged at the megakaryocyte level, they are not being further differentiated into the platelets and result in decreased platelet count. The treatment for drug-induced thrombocytopenia is patient is usually advised to withdraw the medicine and advised to replace the medicine with conditions which do not lead to drug-induced thrombocytopenia. Otherwise, when in severe conditions, that is when the platelet count is severely being depleted, then there is platelet transfusion which is being advised for the patient. Next coming is heparin-induced thrombocytopenia. Unlike the drug-induced thrombocytopenia, the heparin-induced thrombocytopenia actually differs, because since it is less severe when that compared to the drug-induced thrombocytopenia, and it is usually not associated with bleeding condition, but rather it is more prone to formation of thrombotic plaques resulting in thrombosis. So it is mainly because of the administration of the heparin. When patients are taking heparin, then this heparin results in the formation of antibodies. These formation of antibodies are usually, they act against that of the platelet factor 4, which is actually a factor which is present in the granules of the platelets and helps in platelet aggregation. So this heparin, it forms the antibodies against the platelet factor 4 and results in the formation of heparin complex. This heparin complex has an activity that it can cause the activation of the endothelial cells and also causes the initiation of thrombus formation. So heparin, it helps in the formation of clot formation. So it starts resulting in thrombus formation, which could be one of the reason for thrombocytopenia to result because in patients taken heparin. The diagnosis, it is usually made that the patient might show a reduced number of platelets below that of the 1,50,000 level and result in the condition known as thrombocytopenia. Other than that, there are even formation of thrombosis. The other absence of other causes of thrombocytopenia can also be seen. That is, there is no such clinical manifestations of purpura or bleeding into the joints, any such conditions which is normally seen in a thrombocytopenia, whereas in heparin-induced thrombocytopenia. So there is a picture showing the heparin-induced thrombocytopenia where the endothelial cell activation occurs because of the because the patient is being exposed to heparin, and this causes the activation of the tissue factor. It could be platelet tissue factor 4, and this releases this together combines with the heparin and forms antibodies against this platelet factor 4 and results in a formation of heparin-induced thrombocytopenia antibody. And this heparin-induced thrombocytopenia antibody results in the formation of causes the activation of thrombin, which is involved in the clot formation, and this causes heparin-induced thrombocytopenia. Coming to immune thrombocytopenic purpura, usually it is a disorder which is characterized by formation of immunological, where there is immunological destruction of the platelets, as well as there is normal or otherwise increased megakaryocytes in the bone marrow. The basic pathogenesis as underlying defect in this immune thrombocytopenic purpura is because it is majorly based on the duration of the illness, and it is classified into acute immune thrombocytopenic purpura or otherwise chronic immune thrombocytopenic purpura. Acute, it is usually rapid in onset, and it is majorly because seen in children who have been who are recurring from the viral illnesses, and in these patients usually we see that the immune complexes form which contain the viral load in them, and in these patients usually we see that there are severe conditions of the thrombocytopenia, that is formation of purpura, petechia and ecchymosis, as well as bleeding from the gums. Whereas in chronic induced chronic immune thrombocytopenic purpura, we see that these patients usually they are seen in conditions they are unrelated to that of viral, rather they are seen in adulthood and as well as in young individuals, where it is usually gradual onset and lasts for years together. And this chronic induced thrombocytopenic purpura shows severe manifestations, that is bleeding into the joints, and bleeding from gum can also be seen in patients suffering from chronic phase of immune thrombocytopenic purpura. The clinical manifestations usually involve splenomegaly, hepatomegaly, petechial hemorrhages, menorrhagia, nasal as well as gingival bleeding, and intracranial hemorrhage can be seen. Other than that, patients can also complain of bleeding from gums, bleeding from the oral mucosal cavity and other areas within the cavity. The lab findings, usually we find that there's reduction in the total platelet count, as it is a kind of thrombocytopenia, and other than that there's increased megakaryocytes because there is a lack of differentiation of this megakaryocytes into platelets, and rather they are persisting or stagnant, resulting in the stasis of the megakaryocytes. And usually treatment, the patient is advised for spontaneous recovery, and patient is advised for corticosteroid therapy, as well as splenectomy is done to remove that of abnormal platelets, that is immature megakaryocytes removal. So there is a picture showing the purpura spots as well as the oral petechia, or otherwise known as purpura, in the vermilion border of the lip. Coming to the next type of thrombocytopenia, it is a thrombotic thrombocytopenic purpura, or otherwise, and hemolytic uremic syndrome. This thrombotic, it is a kind of microangiopathy, that is because of the alteration of the blood platelets resulting in the vasculature. So it is a thrombotic microangiopathy which is characterized by three symptoms. One is thrombocytopenia, and the second one is microangiopathic hemolytic anemia, and the thirdly, it is the hyaline fibrin microthrombi, which are usually released from the microvasculature of the body. So it is a triad of symptoms, and this thrombi which are being found are usually because when there is any endothelial injury, this releases the von Willebrand's factor, which is usually present within the blood, which is one of the clotting factor, and this results in the formation of microthrombi. This microthrombi, they are present intravascularly, that is within the microvasculature, and they constitute of the presence of platelets as well as the fibrin. Clinically, patients usually manifest with fever, renal failure, as well as palpable spleen, but rather it's not a splenomegaly, but it's a palpable spleen can be seen. Lab findings, usually patients on laboratory examination, that is in peripheral blood examinations here, it shows a reduction in the platelet count, that is thrombocytopenia can be seen. Other than that, a patient might be showing microangiopathic hemolytic anemia can be seen, and leukocytosis, that is increase in the leukocyte count and increased megakaryocytes. So there is a picture showing the for the platelet count in cases of thrombocytopenic purpura, showing the Rolex formation as well as presence of certain neutrophils, and there's complete absence of there are only few platelets present which are being stained as dark blue in color. Coming to the investigations of the platelet and as well as the platelet function, usually we see there are two kinds of tests. One is a screening test which is done just to identify whether the patient is suffering from thrombocytopenia or no. And in these screening tests, usually the peripheral blood platelet count is done, where a peripheral smear is being prepared from the patient's blood, and platelets are being observed under a microscope. Next coming is clin bleeding time, that is a bleeding time is being investigated where the patient is pricked and checked for the time lag between the time of incision to the time of bleeding ceasing, and normally it is 3 to 8 minutes. And next coming is a fresh blood film examination for the to observe the platelet morphology. Next coming in the special tests, these tests are usually special because they usually observe and they try to identify the major cause in the defect in the platelet, that is in the platelet function, at what stage the platelets are defective, whether it is in the adhesion stage or aggregation stage, or because of the release reaction stage, or otherwise in hemostatic stage. So the platelet adhesion stage, it usually observes the presence of the for the receptors that is which are present on the surface of the platelet, and aggregation stage, it observes the presence of fibrin with the help of extra cellularly utilized collagen, and the granular content of the platelets where the granules are being demonstrated, and the platelet coagulate activity for the presence of clotting factors is done. So these are certain investigations for the platelets and the platelet function. Coming to the vascular bleeding disorders, these are usually known as non-thrombocytopenic purpuras because they are not majorly because of the reduced platelet content, but rather they are because of the alterations in the vasculature, and they are also known as vascular purpuras because the patients have been showing manifestations with the presence of purpura, that is pinpoint bleeding points can be seen in the skin. Other than that, they have also petechia which can be observed. They are also reddish purple areas which actually denote that there is bleeding in the particular tissue, and purpuras or ecchymosis is also seen. Ecchymosis, they are similar bleeding areas, but they measure larger than the size of that of the purpura, and there is also variation in the color, and these disorders are usually confined to the skin or the mucous membrane. Usually these vascular bleeding disorders, they are either classified into inherited or acquired based on the conditions where they occur. Inherited vascular bleeding disorders, they are usually because they have been inherited, that is because of a familial tendency or otherwise hereditary in nature, which are being obtained from that of the parent to the offspring. and they are the hereditary hemorrhagic telangiectasia, also known as Osler-Weber-Rendu syndrome. This is a recessive inherited form of disease where the telangiectasia is formed in the vasculature, that is the dilated blood vessels can be seen, which can also result in hemorrhagic hematuria, also in bleeding into the joints, tissues in the oral mucous membrane. So these are few clinical manifestations of the hereditary hemorrhagic telangiectasia. The next coming is the inherited disorders of the connective tissue matrix. So any disorders such as seen in connective tissue matrix such as Ehlers-Danlos syndrome, or otherwise basically any defect in the collagen, can result in inherited disorders of the connective tissue matrix. Coming to the acquired vascular bleeding disorders, they are also known as Henoch. One of them is Henoch Snellen purpura, which is a disorder which is seen which in patients where they usually show presence of purpura, and they are seen in childhood or adolescence age. Sometimes even in elderly patients they are being seen. Patients might comply with similar features such as bleeding, hematuria, and even epistaxis. They are the conditions which are seen associated with Henoch-Snellen condition. Next coming is a hemolytic uremic syndrome. This is a syndrome usually seen with showing group of manifestations associated with the kidney, where there's a bleeding also seen, and there's abnormal or impaired function in the kidney. And next coming is a simple easy breathing, also known as devil's pinches, which is seen in women who are bearing children, and they in these conditions we see there's bruising in these females without any unknown cause. Coming in infections, certain infections such as septicemia and bacteremia, they also show vascular bleeding disorders. Coming to the drug reactions, when the patients are exposed to certain drugs, they might show certain vascular bleeding reactions. Patients who are even on steroid therapy also show these manifestations. And senile purpura can also be seen, and scurvy, that is when there's deficiency of vitamin C, can also result in vascular bleeding disorders. So there is a picture showing the inherited hereditary hemorrhagic telangiectasia, showing telangiectic areas, that is areas showing dilated vasculature, which is being manifested as purpuras and petechias. The next picture showing the petechia and the purpura of the lower limb, which is each because of the vasculitis. Coming to the investigations of the disordered vascular hemostasis, usually the bleeding time is being examined, where the patient's forearm is being pricked, and this time is being noted, calculated from the time of prick to the time where the bleeding stops or ceases, and normally it is of 3 to 8 minutes, but it is being prolonged in conditions such as thrombocytopenia and disordered platelet function or Wallen-Willebrand's disease, in certain vascular abnormalities, and severe deficiency with factor 5 and factor 11. The next coming investigation is Hess capillary resistant test, also known as tourniquet test, because it is being used with the help of sphygmomanometry, where a tourniquet is being tied and the patient is observed from the time of the tourniquet being tied, and the patients who develop petechia more than 20 times, more than 20 petechia, then the patient is said to be consisting of disordered vascular hemostasis. So it is positive usually when there is increased capillary fragility, as well as in cases of thrombocytopenia. So these are certain investigations of disordered vascular hemostasis. Coming to the next is coagulation, or otherwise known as clotting cascade. So coagulation or clotting is defined as a process by which blood coagulates from a liquid to a gel stage. That is it results in a coagulation formation or clot. So it is known as coagulation or clotting. Coming to the clotting factors, these are usually the proteins which are present in the blood, and they are involved in controlling the bleeding, and so they are known as clotting factors. Coming to the definition of clotting process, usually it is a process which constitutes of many different clotting factors which together work and result in the formation of series of chemical reactions, and they stop the bleeding. And the general steps, what happens in clotting is on injury, they are usually since the first line of cells which reach are platelets, and then followed by platelets. Once they reach, get attached to the wounded approximated edges of the wound, and once these get attached, they start, that means these platelets are activated and they release certain factors such as which are present in the granules of the platelets, and followed by this there's white blood cells, particularly the neutrophils, based on the type of injury. In case of acute injury it is the neutrophils, whereas in chronic injury it is the macrophages. These white blood cells, once they reach the site of injury, they get activated and they start showing their effect, that is they debride the area, or that is they remove the foreign antigens from the area and they prepare the area for healing. So once the white blood cells they reach, they initiate the vascular spasm, that is bleeding is stopped, and that forms results in the formation of platelet plug. And this platelet plug, once it forms, these platelets they start moving towards the source of the chemical signals and they start binding there, and result in the platelet plug which has been formed. It starts growing in size. Once the platelet it starts growing in size, it results in formation of fibrin, and this is mediated with the help of formation of fibrin from the activation of plasminogen to plasmin, and this forms a thrombus and it results in the formation of fibrin, which is a major content in the clot. And this fibrin, it forms in the meshwork like pattern, and thereby it interlocks the clot which has been formed and results in a formation of clot. So this is what happens in the general steps of clotting. And this clotting cascade, it is usually occurs in three pathways. One is the intrinsic pathway, then is the extrinsic pathway, and then is the common pathway. So these three pathways, they make up the classical blood coagulation pathway. In the intrinsic pathway, usually on contact with any surface agents, there is activation of the clotting factor 12. Clotting factor 12, it activates and results in the formation of activated clotting factor 12. And this activated clotting factor 12, it mediates the activation of factor 9 to activated factor 9, and this activated factor 11, it mediates the activation of factor 9, and then this activated clotting factor 9, it results in it mediates the activation of clotting factor 10. And this also mediated along with clotting factor activated 9. Along with that, it also requires the clotting factors 8 as well as calcium for the activation of 10 to 10A. This once the clotting factor is 10A is being activated, it further proceeds from extrinsic pathway, where once there's any tissue damage, there will be activation of clotting factor 8 in presence of tissue factor. Other than that, this activated clotting factor 8, it also mediates the activation of clotting factor 9 to 9A. Both of them together mediate now the common pathway, which is initiated with the activated factor 10. Clotting factor 10. Along with that, certain other factors, that is the calcium, causes the conversion of prothrombin to thrombin, and this thrombin, which consists of serine protease enzyme, this causes the mediation of activation of the clotting factor 8, and this clotting factor 8, once it is formed, it results in the formation of stable fibrin clot. This thrombin, which has been formed from the activated factor 10A, it also mediates the activation of fibrinogen to fibrin, which might also result in stable fibrin clot. So these are certain series of reactions which occur in a coagulation cascade reaction. Coming to the regulation, how the coagulation system is being regulated, it is usually regulated by protease inhibitors as well as with fibrinolytic system. And this fibrinolytic system, it usually consists of tissue type plasminogen activator as well as urokinase like factor. So this plasminogen, which is usually present in the fibrinolytic system, which mediates or regulates the coagulation system, this plasminogen is first usually present in an inactive form. It usually activates and results in formation of plasmin. And this plasmin, once which is activated, it mediates the formation of fibrin to fibrin degradation products, and this results in the formation of clot. The fibrin which has been formed, it usually mediates the activation of thrombin to thrombin activable fibrinolysis inhibitor. This is also involved in the coagulation system. Other than that, the plasminogen to plasmin, so the conversion of plasminogen to plasmin usually occurs with the help of tissue plasminogen activator. This tissue plasminogen activator, it is usually produced from the plasminogen activator inhibitors, that is they are the protease inhibitors which constitute type 1 and type 2. These protease inhibitors, they also release an enzyme known as urokinase, which also has a function in mediating the activation of plasminogen to plasmin. The other factors which regulate the coagulation system, they are the factor 11A and factor 12A. These are the activated factors. And this plasmin, it is also being released from the alpha-2 antitrypsin and alpha-2 macroglobulin. So these also released in the plasmin factor. So this is the regulation of the coagulation system. Coming to the coagulation disorder, so any systems which are being altered either in intrinsic pathway, extrinsic pathway or coagulation pathway might result in coagulation disorders. These could be the hereditary disorders or the acquired disorders. Amongst the hereditary disorders, it is a classic hemophilia or also known as hemophilia A, or otherwise the next coming is Christmas disease or hemophilia B. The other one is von Willebrand's disease. So these are certain hereditary coagulation disorders. Next coming are the acquired disorders. They are the vitamin K deficiency. They could be either because of the vitamin K deficiency or because of the coagulation disorders resulting because of the liver disorders, or otherwise because of the fibrinolytic defects, or also seen in conditions such as disseminated intravascular coagulation. So these are certain coagulation disorders which could be either because of hereditary or otherwise acquired. Coming to the classic hemophilia A, usually it is an X-linked recessive inheritance. Because of the pathogenesis, it is usually seen most commonly in the males, where females occur as carriers, and the clinical features, since this is an inherited disorder, it is usually from the parent to the offspring, and it is X-linked recessive. It means that they are only carried from the fathers to the children, and where females act as carriers. And the clinical features, usually we see bleeding as a major feature, where the hemorrhagic areas, they are seen in the tissues, joints, or bleeding from the nose or from the oral cavity, that is the oral mucosa, or from the gums. These are certain clinical features. Coming to the laboratory findings, usually we find that there is a decrease in the anti-hemophilic factor, and this is a major laboratory finding. And once there is deficiency in this anti-hemophilic factor, or this results in classic hemophilia. And the treatment, usually patients are usually supplied with the replacement of this deficiency in this clotting factor with the help of clotting factor 8. Coming to the Christmas factor, which is also known as hemophilia B, and it is usually because of the deficiency in factor 9, clotting factor 9, and it is completely indistinguishable from that of the classic hemophilia. That is a similar clinical features, and the signs and symptoms are being observed as that of classic hemophilia A. Usually a bioassay of factor 9 is done, where it shows a lowered activity of this clotting factor 9. And the treatment in these patients, usually patient is supposed to be given fresh frozen plasma, or otherwise plasma which is being enriched with factor 9. Coming to the von Willebrand's factor, it is usually classified into 3 major diseases, that is type 1, type 2 and type 3. So this is usually because of the deficiency in von Willebrand factor, which is one of the agents which is used in clotting factor. Coming to the laboratory findings, which we usually see is the bleeding time is usually prolonged, whereas the platelet count is usually normal. And the plasma von Willebrand factor concentration, usually it is present in usually it is reduced than that of the normal, and the platelet aggregation with antibiotics is seen. That is when the platelet aggregation has been demonstrated, it has been shown that there is defective in the platelet aggregation, because of which there is more bleeding tendency in these patients. And there is also a reduced activity of factor A in such of von Willebrand's disease. So the types of von Willebrand's disease, they are usually of 3 types. They are the type 1. It is mostly because when the von Willebrand's factor within the plasma or the circulating blood is only up to 50% of that of the normal. So then this results in type 1 disease. Type 2 disease, it is usually the levels of the von Willebrand's are normal, but rather there is a derangement in the functional activity of this von Willebrand's in coagulation. And then coming to the type 3, it is the most severe and most commonly seen disease amongst the von Willebrand's disease, where we see that there's completely absence of the von Willebrand's factor, and it's followed by its activity. So these are the clinical features of von Willebrand's disease. Coming to vitamin K deficiency, since vitamin it is a fat soluble vitamin, it plays a major role. Major function of vitamin K is in hemostasis, as vitamin K helps in the synthesis of certain clotting factors such as clotting factor 2, 7, 9 and 10. So any deficiency in vitamin K will in turn result in the deficiency of these clotting factors and causes bleeding. So this vitamin K deficiency can be seen neonatal, by birth only. So in these conditions, usually the patient manifests with hemorrhagic disease as well as liver cell immaturity. So in these conditions, in neonatal vitamin K deficiency, when this vitamin K supplements are given to these patients, they rapidly revert back to normal condition and normally start functioning. So there's easy recovery in the neonatal children. Coming to vitamin K deficiency in children and adults, it is most commonly seen because when the patients take inadequate intake of the vitamin K from the exogenous source diet, or otherwise when there is sufficiently intake in vitamin K, but rather it is not being absorbed properly. So in conditions such as intestinal malabsorption, that is when there is any changes in the gut or otherwise any liver disorders, this might result in vitamin K deficiency. And also in certain hepatocellular disease, since vitamin K is completely dependent on the organ liver for the synthesis of its certain functions such as clotting factors or otherwise its absorption and its storage. So any hepatocellular disease might also result in vitamin K deficiency. Coming to the coagulation disorders in liver disease, it could be show a morphologic lesions, such as it could result in portal hypotension, peptic ulcerations and gastritis. So these are the disorders which we see when the coagulation disorders are because of the liver disease. And hepatic dysfunction can also be seen. In these patients, we see that there's impaired hepatic synthesis, since liver is also involved in synthesis of certain clotting factors. So this impaired function of the liver might result in impaired function of the clotting factors, and also impaired hepatic synthesis of the coagulation inhibitors. That is, certain inhibitors which are being involved in conversion of plasminogen to plasmin, as well as in the fibrin plug formation. There's also alteration in these biological mechanisms because of the impaired hepatic synthesis. Next, coming is the impaired absorption and metabolism of vitamin K. As already explained, vitamin K must have been sufficiently produced by the diet, but rather its absorption and its further metabolism might be deranged, because of which might result in a coagulation disorder. And next coming is a failure to clear the activated coagulation factors. That is, then the coagulation factors have been completely activated, but rather they are not being utilized in the coagulation pathways. This might also result in coagulation disorders. Coming to the complications of the therapy, that is, when the patients are being supported with the therapy, such as for these coagulation disorders, it might result in certain complications, such as in massive transfusions. There might be complete dilution of the platelets as well as a clotting factors. Next complication is the infusion of activated coagulation proteins. So when there is infusion of this activated coagulation proteins, it might also result in alteration of the coagulation disorders. Following with heparin therapy. Heparin, since it acts as an anticoagulant, it might result in hampering of the clotting function and result in coagulation disorder. Coming to the investigations of the blood coagulation, they are being classified into screening tests and special tests. Screening tests should to know whether this patient is suffering from coagulation disorders, and these are blood coagulation time is being measured, as well as partial thromboplastin time is being done with the help of kaolin, which is usually done as an activating factor. On exposure to this kaolin, there's activation of the clotting factor, so there's one done. And next is the one-stage prothrombin time, which is usually done to measure the clotting factors such as prothrombin. And next coming is a measurement of the fibrinogen, which is done usually with the help of fibrin formation during the with the help of test tube. So these are certain screening tests which help in establishing that the patient is suffering from blood coagulation disorder. Then special tests are done. These are usually done with the help of coagulation factor assays, where all the in this coagulation factor assays, this consists of a solution where all the coagulating or the clotting factors are present, and thereby they are observed particularly for which clotting factor is actually supposedly causing this coagulation disorder. Next coming is a quantitative assays, that is the total amount of each clotting factor, that is the quantity of each clotting factor is being measured in this quantitative assays. So these are certain investigations for blood coagulation. Next coming is a fibrinolytic disease. Usually fibrinolysis, it is an essential protective physiological mechanism which consists of plasminogen this plasminogen is nothing but plasmin and fibrin degradation products. So this is a fibrinolysis which is normally seen, but when there are any defects that are such as in fibrinolytic defects, there is alteration in the formation of this plasminogen. And this primary pathologic fibrinolysis, it is usually because of the deficiency of the alpha-2 plasmin inhibitor, which is usually involved in conversion of plasminogen to plasmin, which thereby results in formation of a fibrin plug. So there is deficiency of this alpha-2 plasmin inhibitor, which thereby results in alteration in the formation of fibrin plug. Next coming deficiency is because of impaired clearance of the tissue plasminogen activator. That is, when the activator for plasminogen when the activator for plasminogen to plasmin is being present, this might result persistently presenting this activator might result in impaired clearance, and this results in fibrinolytic defect. So it is very difficult to distinguish distinguish primarily from secondary fibrinolysis, such as fibrinolysis accompanying the disseminated intravascular coagulation is difficult to distinguish from fibrinolytic defects. Coming to the investigations of the fibrinolytic system, usually it further consists of screening tests, that is the fibrinogen is being estimated, that is the fibrin being formed from the activation of the plasminogen to the plasmin mediated by certain inhibitors as well as activators. And the fibrin degradation products which are present in the serum are also being estimated. And other than that, the other additional tests, they are the ethanol gelation test, where ethanol is being utilized in this test, and conversion of this ethanol from gel to that is, conversion of ethanol is being done from salt to gel test. This is done in this ethanol gelation test. Other than that, it is a euglobulin or otherwise whole blood lysis time is done, where the blood lysis time is being estimated, and these are the tests which usually establish that the patient is suffering from defective and fibrinolytic system. Coming to the specific tests, that these are the tests which usually actually establish that the patient, the reason what the defect in fibrinolysis is. It is done with certain functional assays with the help of ELISA, where enzyme linked immunosorbent assay is done to identify the functional qualities of the fibrin. And other than that, there are certain immunological assays also which are being carried out, and chromogenic assays of the plasminogen activators are also being done in investigations for fibrinolytic system. The next disorder is disseminated intravascular coagulation. It is most commonly done when there's secondary fibrinolysis. In case of massive tissue injury, when there's a sudden rapid injury or heavy injuries, then this could result in disseminated intravascular coagulation. Also in infections such as septicemia and syphilis induced reactions, we see disseminated intravascular coagulation. It is a widespread disease, and it was also seen in conditions such as endothelial damage, as well as certain other functions such as in bleeding disorders, in hemolytic anemia or hemorrhagic disorders. There is disseminated intravascular coagulation seen. The pathogenesis involves, initially it is because of the activation of the coagulation system, that is the clotting factors which activate and result in the formation of a clot. This clot which is formed results in the formation of a thrombosis phase, that is it gets dislodged and reaches into the blood circulation, and thereby it is being consumed by the in the consumption phase, that is the clotting factors as well as certain other contributing factors in the clotting system, they are being consumed rather than being showing the function in the formation of clot, they are being consumed, and this results in secondary fibrinolysis, that is secondary indigestion of the that is the fibrin which is formed is being digested or dislodged or being degraded. So this is a pathogenesis for disseminated intravascular coagulation. The laboratory findings in the patient suffering from disseminated intravascular coagulation is low platelet count can be seen, that is the platelet count is decreased below 1,50,000 per microliter, and this condition is known as thrombocytopenia. Other than that, anemia is seen, that is patient might be suffering from microangiopathic hemolytic anemia, and when the prothrombin time and the thromboplastin time as well as activated partial thromboplastin time have been estimated, then the patients show prolonged duration, that is they exceed that of the normal range in these conditions, and there is also reduced plasma fibrinogen levels as well as the fibrin degrading products, they are raised, which result actually in degradation of the fibrin which has been formed by the clotting system. So this is a disseminated intravascular coagulation. So there is a picture showing a kidney biopsy showing the presence of center thrombus formation which is being stained with hematoxylin and eosin stains.